I'm here to share with the House how Zimbabwe has, the journey that Zimbabwe has walked in implementation of HIV care with a special focus on adolescents. And for my presentation, I've got no conflict, conflict of interest to declare. Just as a matter of introduction, Zimbabwe is among the high-burden countries in terms of HIV prevalence. And when we look at the region, that sub-Saharan Africa, we're actually among the leading countries with regards to this problem. We've got an estimated 1.3 million people living with HIV, and of those, 7% are children. Currently, our estimated HIV prevalence in the reproductive age group stands at 13.8%. And what we've noticed is women are affected more than males. And we have what we call a generalized epidemic, which is mainly driven by unprotected heterosexual transmission. However, we're also noting that the prevalence among the key populations, particularly female sex workers and men who have sex with men, is higher than what is actually reported in the general population. This slide is just showing us what has been happening to the prevalence of HIV among the young people, adolescents included, between 2014 and 2017. I think I need to emphasize the fact that in Zimbabwe, what we actually call an adolescent is not who the strict definition refers to, because we also include even young people up to the age of 24. So you will note that in my presentations, I'll give statistics at times that relate to the 10 to 19, 15 to 24, and so on, because we are covering the age groups from 10 to 24. So this slide is actually showing us that generally there has been a decline in the prevalence of HIV across all age groups. But what I need to emphasize is the fact that, even shown on this graph, is the fact that the prevalence in females between the ages of 15 and 24 is higher than what's actually reported in their male counterparts. Again, showing a bit of statistics on the prevalence in Zimbabwe, we notice that the 10 to 14 age group prevalence is lower than the prevalence reported in the 15 to 19, and even lower than what's actually reported in the adults. But again, of note is the higher prevalence in the females, as illustrated by the bar graph projected here. And the line graph is showing us the trend in terms of the actual numbers of people living with HIV and what has been happening over the years. What we've noticed is in the past 10 years, there has been a decline in the prevalence of HIV in the general population. The same has been reported in young women and young girls. But what we're noticing is that in the males or in the boys aged between 10 to 19, we have not yet started noticing a decline in the prevalence. There is a slow but gradual increase as estimated. And what has then been our experience in terms of the evolution of the program? Zimbabwe started offering HIV care services in 2004. And I think what I need to highlight is the fact that our program has really been informed by evidence that has been generated locally, evidence that has been generated in the region and even globally. So we started offering HIV care services in 2004, and we started off with 5 pilot sites, and these were mainly at the 4 central hospitals. Wilkins Hospital, which is where I'm working, was actually one of the 5 pilot sites then. And we worked over time to roll out the programs to other sites, and we adopted the public health approach in the rollout of, or the scale-up of services. And what we did was to simplify the processes. I think when we started, the process of counseling would really take, like pre-test counseling would really take long. But we noted that that was actually posing as a barrier to services, and we had to simplify the process of counseling, we had to simplify the process of testing. Regarding treatment, when we started offering ART, for example, this was really the domain of physicians and pediatricians. But we noted that that actually served as a barrier. And we had to simplify the process so that we actually took it a step further to general practitioners, to junior doctors. And now our program is actually driven by the nurses who do most of the initiations, they do most of the follow-up of clients who are on treatment. And again, we had to simplify monitoring. I think when we started, what we were doing was we're actually depending mainly on lab monitoring, where we would do a whole lot of baseline tests before initiating clients on treatment. And then during the course of treatment, we also needed to do such things as the full blood count, liver function test, kidney function test as routine. But we actually noted that we could use clinical monitoring, and it worked almost equally well as lab monitoring before initiating clients on treatment and even during the course of treatment. And we had to standardize how we were doing things through the development of standard operating procedures, through the development of job aids, and even the dosage charts. And this made it a lot easier for the nurses at the peripheral sites to offer services. We looked at issues around equity, accessibility in terms of geographical location of sites, accessibility in terms of cost, where the service was actually made free to the clients, and even acceptability of the program itself. We then worked out on a program where we decentralized the services to the lowest level of care. And currently, we have about 84% of our sites or our health facilities in Zimbabwe offering ART services. And all these are also offering ART services to children and adolescents. We're not doing so well in terms of sites offering isoniazid preventive therapy, and even the EPMS, which is the electronic patient monitoring system, because we are at less than 50% in that regard. So where do we currently stand in terms of service provision? For the next few slides, I'm just going to look at areas that are relevant to the 90 targets. That's how we're doing in terms of testing, treatment, and viral suppression. So as of end of 2017, we were at 52% in terms of testing among the 15 to 24 year age group. And that's not so good. And what we've noticed is that the uptake of testing among the young boys and young men is low. And we were actually working on ways to increase the uptake of service so that the young men and boys who are living with HIV actually get to know their status. Treatment-wise, we were at 84% in terms of ART coverage among the 15 to 24. And in terms of viral load, we were at 85%. And I think when we compare ourselves with our neighbors, we almost performing at the same level. And this bar graph is just breaking down the 15 to 24 according to sex and showing us how we're doing in terms of coverage. Again, we're not doing so well. This was actually at the end of 2015, and it was according to the Zimfia study. So when we did our evaluation end of 2015, we noticed that ART coverage among the children and adolescents was very low. And we then came up with what we call the accelerated action plan for a scale-up of ART services for adolescents and children. In this action plan, we actually came up with ways of rearranging our space, rearranging our service delivery to increase identification of adolescents living with HIV and also to link them to care. And I think that helped a lot to increase our ART coverage. And as of end of March this year, our ART coverage among the 10 to 19 year age group stood at 91.7%. And looking at adherence among the adolescents, I think we're not doing so well. According to the study that was done by Takarinda, we actually noted that among the 15 to 19 year age group, 89.5% reported adherence rates of above 95%. So it means that the remaining were not adhering well to treatment. And we know for adequate viral suppression, we need adherence rates of at least 95%. And comparing the same to the those that are age 20 and above, we notice that adherence is a bit lower among the adolescents. Retention, again, is also lower among the adolescents. The black line there is actually referring to adolescents aged between 10 and 19. And we notice that compared to the adults and even the younger children, our retention in care, both at 12 months, 24 months, and 36 months, is lower in the adolescents. And obviously, this will then reflect even on the viral load suppression, where we notice that the 10 to 19-year age group the proportion that's actually virally suppressed is lower than the what we're getting in the older age groups. And in the first quarter, we did an analysis of, where we looked at the cascade along the continuum of care, both for children and for adolescents. And what we noticed was that we continue to getting leaks at every stage of the cascade, where when we identify children or adolescents that are living with HIV, some of them do not get linked to care. Of those that are linked to care, a certain proportion is not finally enrolled. And of those that are enrolled, some are not initiated on ART. And we've actually tried to establish why we continue to get those leaks. And some of the reasons are actually related to the guardians or the parents that look after the children or adolescents. We also have reasons that are related to the health system itself. And we also have some of the reasons that are related to the adolescents, where perhaps sometimes they feel that they're still healthy and they don't want to be initiated on ART, or they feel they'll be stigmatized, or maybe they're at school and they don't know how they'll cope with taking medication whilst they're at school. We adopted and implemented the differentiated care model as one of the innovations that has helped us in the scale-up of adolescent HIV care. And I think the slide was talked about by my colleague from Zambia, but basically it talks about differentiated HIV testing services for adolescents, where we're looking at when do we offer the testing, where do we do it, whom are we targeting, and what exactly are we taking into consideration. And for differentiated ART delivery, what we've then done as a country is we've actually come up with models where adolescents that are stable on treatment, they're virally suppressed, they're clinically stable, are actually not required to come for reviews or for clinical reviews every so often. So we've actually reduced the number of visits to 2 per year. So they're sent for reviews every 6 months. However, they still need to come for their clinical refills or for the pharmacy visits every 3 months. And we've got clubs where adolescents have actually grouped and formed ART refill clubs. And this is actually helping a lot in terms of retaining our adolescents in care. So what are the key adolescent challenges that we had to consider when we were scaling up services? We had issues around access to health services, regarding the actual location, regarding the cost. When you talk about going to the clinic for refills, bus fares are a major issue for some of our adolescents, and even the attitudes of the healthcare workers within the health facilities. The legal framework, I think, was talked about yesterday, looking at issues around consent, consenting to services, consenting to testing as adolescents, and the need for parental or guardian consent. And then disclosure issues, adherence issues, retention in care. I think I made reference to that in previous slides, and even issues around relationships involving adolescents. So these are some of the innovations that we've had to put in place to try and address some of those key challenges. To increase access to health services, we had to decentralize our services. We also worked on making our health services adolescent-friendly. And in terms of disclosure, we've worked a lot with what we call expert patients or peer counselors. These are basically adolescents that are living with HIV, and they've been trained in peer counseling. So they offer a lot of psychosocial support, adherence support, and even help adolescents with disclosure. Adherence, viral suppression, and even retention in care. The adolescent supporters are helping a lot. We're also working very closely with Africaid through the community adolescent treatment supporter program, where adolescents that are living with HIV actually serve as the link between the facility and the community, and they do pay home visits to the adolescents and help them in terms of adherence support and psychosocial support. This picture is just showing us a picture that we took when adolescents came for a support group meeting. This was actually at the hospital where I'm working. So our adolescents meet once a quarter every school holiday. And when they come, they do a lot of playing. They learn through playing, they interact, they share their experiences, and they play games. So these are actually showing us the sister in charge dressed in green. They're playing games with the adolescents. And when we also conduct the meetings, we invite celebrities that the adolescents identify with. The man shown here is actually a Zim dancehall musician, and I think adolescents in Zimbabwe like Zim dancehall music a lot. So when you invite those celebrities and then you deliver key messages through the celebrities, they actually take the messages better than when the messages are delivered by healthcare workers. Right. I think in implementation, we can never overlook the need for partner support. We have had to ride a lot on the support that we've been getting from a lot of partners. These are just some of the partners that are supporting us in the implementation of adolescent HIV care. I mentioned earlier on the support that we're getting from Africaid, and they've helped us to set up adolescent-friendly services, adolescent centers, and this is just one of the centers that are dotted around Zimbabwe. In the adolescent centers, we've got equipment for edutainment, we've got books, we've got games, and the adolescents come in here, they interact, they learn through the videos that are shown, and they share their experiences. And the two colleagues that we're actually seeing here are some of the community adolescent treatment supporters that we work with. And when they come, they also do a lot of things. This is a tree that they put together, and they call it the Tree of Life. They actually use the containers for ARVs to make up this tree. So what are the lessons that we've learned in the past few years? We've actually noted that involvement of expert patients in adolescent HIV care does improve their health-seeking behavior, and it improves the rate at which they take up services. I think one message that has been coming up strongly from the adolescents is nothing for us without us. So we've had to involve them in a lot of the services and the programs that we're running. And basically, adolescents take up services better when health education is a package in a way that they like, in a way that they enjoy. I think we heard this over and over again yesterday. And the scale-up of adolescent HIV care services does require a significant amount of partner support. What are some of the challenges that we've been experiencing as a program? I think like any other country in the sub-Saharan Africa, we are faced with human resources challenges. Our data management system is mainly manual, so that also comes along with even issues around the quality of the data that we're working with. Though we try to triangulate and use the data from the various sources, occasionally we experience disruptions in the supply chain management system around HIV-related commodities. And we've also noticed that our adolescents are highly mobile, And sometimes they give us incorrect contact details. When we then need to follow them up, sometimes we can't locate them. In conclusion, ladies and gentlemen, I think these are just my 3 key points, which I think made reference to in detail in my presentation. On that note, I would like to thank you.